Welcome to the Research Reimagined podcast, brought to you by Nottingham Trent University. I'm your host, Helen Darby-Dowman, and I'll be inviting some of NTU's brightest minds to explore how their research is helping us to deepen our understanding of the world. From online addictions to transgender rights and sleep disorders. Listen as we discuss some of society's most pressing challenges and uncover some of the ways our research is making a difference. In today's episode, we're going to be exploring the topic of mental health amongst African and Caribbean mothers. Our guest today is Dr. Dung Jidong, a senior lecturer in psychology at NTU. Dung, thank you very much for joining us.
Glad to be here.
As women, we are twice as likely to be diagnosed with clinical depression than men. You might be thinking that this statistics makes sense. After all, research shows men are less likely to visit the doctor about mental health concerns compared to women. However, black women are 50% less likely to seek medical assistance than white women, and they are 20% more likely to be ignored by their GPs. The health disparities between black and white women don't end there. Black women are less likely to be diagnosed with ovarian cancer and endometriosis, and statistically experience shorter life expectancies and higher rates of maternal mortality. Despite some improvements over recent years, the mental health of Afro-Caribbean mothers is still incredibly under-researched, and many black women's experiences and voices continue to be marginalised. Our guest, Dr. Dung Jidong, is going to explain the realities that Afro-Caribbean mothers in the UK are facing and explain what needs to be done to better support them and their journey through motherhood. So, Dung, some of the statistics that I've just mentioned are clearly very problematic. I mean, could you start by explaining a little bit about your role here at the university and also about your area of research?
Thank you. So here at NTU, work as a lecturer in Black and cultural psychology, and also I teach in other area of modules, but my primary teaching duties is within the area of Black and cultural psychology.
And can you tell us a little bit about the areas, as in what you've been actually researching?
I basically do a lot of research, but at the minute, putting more energy in doing cultural adaptation for psychological intervention in different areas of mental health disorders, but with more focus on the people of African and Caribbean origin here in the UK, and of course, working with other African and Caribbean countries like Nigeria, Kenya, and Jamaica.
And I know that you've been doing some work on reverse innovation. Can you talk to me a bit about that work that you've been doing with your mentor and kind of what that involves?
Oh, thank you. So again, my research mentor, Professor Nusrat Hussain of the University of Manchester, we have been involved more recently in all sort of discussion thinking around reverse innovation, where we understood that since hitherto, there has always been some kind of demonization of values, beliefs, and things that actually work well or perhaps sustainable from African and other low-income countries. So now we're thinking through reverse innovation, where we begin to harness some of these experiences, some of these knowledges that we are learning from these African and low-income countries, and see how those can actually be used and even made more sustainable here in the Western or more high-income countries.
Is this work kind of first of its kind?
Yes, so there is not really much research in this area. So we're still thinking more vividly. For example, what we're doing in some of the research, looking at mental health in Nigeria and Kenya, what has really worked well, and how can we bring those ideas into African and Caribbean communities here in the UK.
Can you tell me how you got into your area of research? I mean, was there anything in particular that led you in that direction?
Right. So my educational training, it's kind of have shown some sort of a clear trajectory into what I'm doing today with regard to teaching, research, and practice. For example, my first degree was in general and applied psychology, and then my master's degree was in clinical and community psychology, and my dissertation was looking at the challenges faced by mental health interpreters in East London, and I got a funded PhD to explore the impact of cultural beliefs on mental health in Nigeria. So if you see this kind of a trajectory of my educational training kind of tie closely to my current research, looking at cultural adaptation for mental health problems or disorders, if you want to put it that way. I'm talking about mental health. It's not really something that it's common, and people just get along with their daily activities regardless of their emotional distress. And mental health problems are only seen as problems when those individuals have reached some kind of degradable level where they can't look after themselves anymore. That is only when they see this as a mental health problem. But, you know, anxiety, depression, etc., are not always seen as a mental health problem.
So it's very severe before any intervention is brought in.
Yeah, that's right. And again, but cultural and religious beliefs kind of not really permit conversation around mental health problems.
And was it something that when you came to the UK that you became very aware of, that actually that wasn't the norm? Or were you already fully aware of the fact that the difference in different cultures and the support that people get around mental health?
Because I studied psychology undergraduate, so obviously we were exposed to all sort of mental health disorders in the different levels of our undergraduate degree. Aside from understanding of the literature, you might also be aware that in Nigeria, as a developing country, we don't really have a proportionate level of mental health practitioner. So the ratio between mental health practitioners and potential service providers is very, very poor. So the mental infrastructure is first of all, the mental infrastructure is not adequate, and secondly, it's not something that is talked about. And to a large extent, when people begin to have severe mental health experiences, they are likely going to seek for religious and traditional healings rather than going to modern or perhaps orthodox mental health services.
So the statistics that we introduced, obviously at the beginning of the episode, I mean, they're clearly quite problematic, and it is quite shocking that the racial bias and discrimination affects Black people's medical care so much to this day. Could you please explain where some of these shocking attitudes come from and how this is affecting Black people?
I mean, historically, we understood that there are up to today some legacies of slavery, colonization, racism, systemic oppression, and so many other social factors that are impacting on why people of African and Caribbean origin access mental health or not. Now, if you go down memory lane looking at historical era, beginning from the slavery point where most, or especially the field of medicine, was kind of built on the suffering of Black people, and one of which, if you can remember, the classical work of Dr. James Marion Sims, where he basically conduct all sort of experimental surgeries on Black women or enslaved Black women around the use of anesthesia, or subjecting them to giving birth without any form of pain reliever. So all these are kind of historical happening that have up to today impact on why most people of African and Caribbean origin are likely to be reluctant toward accessing uh, mental health care.
I mean, it talks about that Dr. James Marion Sims, he obviously didn't use anesthesia in a lot of these operations, and that very much impacts on the thinking of pain and how Black people, Black women actually perceive pain. I mean, is there more you can talk to me a bit about that in terms of how that really does impact?
I mean, even in modern day, we're thinking in terms of our cultural beliefs and how these cultural beliefs have significant impact into decision of help seeking behaviors for mental health care, etc. Because of this distrust that has been persistent within the care sector, that has kind of ingrained into the cultural and religious beliefs of African and Caribbean people. For example, there is this general perception that as a typical African mom, you should show strength and help seeking behavior for emotional distress or mental health problems or perhaps postnatal depression. It's a sign of weakness, and it's also seen as a potential taboo that women shouldn't express.
There's obviously, you mentioned, and the research is that there's a lack of trust that African and Caribbean women have in the medical system, and how important actually it certainly as um, in the maternal state and then new mothers, how much we actually rely on or need that care. Can you talk to me a little bit further about kind of that lack of understanding and probably the cultural understanding within that profession?
For example, we can, there are tons of literature showing the implication of our cultural belief, which is one of the key determining factors as to whether we are going to access whatever kind of services that are readily available at our disposal. Now, we have a misrepresentation of mental health practitioners of the African and Caribbean origin within the care sector, and that is one. And secondly, sometimes you have a typical uh, Caucasian white middle class male who is a potential care provider for a typical Afro Caribbean mom. So now there is kind of a misunderstanding in terms of what are the cultural etiology, what are the cultural implication of the belief behind the diagnosis or even the treatment. So it's always a difficult task. So I think one of the biggest challenge is actually ingrained within the care profession itself.
And do you think there's any other reasons today why Black women are not as likely to seek medical health support?
Of course, we kind of at a minute looking at how cultural and religious beliefs sort of impact on the reasons why people of African and Caribbean origin are likely to be reluctant toward healthcare seeking behavior, and this is partly something to do with this belief system as to what or to what extent can they really rely on the care provision. That is one. And then secondly, some of these moms might have had experiences, probably not direct, but maybe they are linked to their social groups of other moms who have expressed emotional distress to social services or to their care provision, and sometimes they risk getting their children taken away from them within the guises of mental incapacitation. So yes, these are some of other factors where moms of these communities are less or highly reluctant, or perhaps expresses low uptake of mental health care services.
You already mentioned that, mental health issues can be seen, well, are seen as a taboo within these communities. Why is that? Is there a specific reason?
Actually, this sort of within the context of cultural and religious beliefs, where some of people in African and Caribbean communities believe that mental health issues are external to the individual, and so when they pray over this, they can easily get healed. And then, from cultural perspective, these are also saying that as a typical Afro-Caribbean mom, you shouldn't express any form of mental health distress, because that would suggest some level of weaknesses on the side of the mom. But if we look at this from a more logical, side of things, where being pregnant, giving birth to a newborn, and having to nurse that little baby, which depends on the mom almost 100% on the baby's survival, we can say that these sort of activities are, both physically and emotionally draining, and people might be experience some sort of emotional breakdown, and people or mom should be able to find a conducive atmosphere to seek help or support where necessary. However, when some of these mom express this sort of mental health distress, they might be seen as though they are incapacitated to look after their children. For example, here in the UK, African and Caribbean moms are 4 times more likely to be detained under the Mental Health Act, much more than any other ethnic group in the country. So this sort of, also raises our eyebrows, thinking around systemic injustice that are paramount in this community.
I mean, there must be a lot of fear within that community of obviously expressing any of that compared to, I know from my own experience of becoming a mum and actually you seeking people to talk to. I mean, that clearly is something that needs to be looked at and addressed.
Absolutely. In some of our previous research, like the one I mentioned, we conducted focus group discussion with some of the moms from these communities, and some of them have actually attested to potential experiencing when they risk their children being taken away from social services. So these are some of the reasons that kind of culminate into the broader issue around the uptake of mental health care within these communities.
And I know you run a research project called Learning Through Play plus Culturally Adapted Cognitive Behavioural Therapy. Tell me more about that project and the aims for it.
This project, all started from our preliminary work that I mentioned, systematic review, focus group discussions, and public and patient involvement event. The preliminary findings from these studies then necessitated the project that we're doing now on learning through play plus culturally adapted cognitive behavioral therapy for treating depression among the British mothers of African and Caribbean communities. So our understanding was, the fact that depression itself is the leading cause of disease burden, and this is only going to be increasing up to 2030. Now, it's even more difficult when these moms have children, young children who require all sort of support for their basic survival. And that's where we understood that this is a neglected area, and this study is actually one of the first of its kind to support moms from the African and Caribbean community. And again, because children at the ages of 0 to 3, or perhaps down to 5 and 6, rely on the mom, the attachment to the mom, and that sort of determine the adequate support they receive to help them to be school ready. We understood as well that about 40% of Black pupils and students are likely to drop out of school due to significant lack of parental warmth from their parent. And we understood again that depressed moms are much more vulnerable and even susceptible to self harm, which then suggests that the moms have to be mentally and physically healthy. That way, they can be able to support the children and help them to be school ready, and also to build resilience to help them challenge social vices that might be at their at their disposal. So the intervention itself, it's a psychological intervention. It's behavioral and doesn't involve any form of medication or antidepressants. So it's online. We help this intervention online via Microsoft Teams, and it lasts approximately 60 minutes. So it's a 12-session parenting training where we train moms how best to look after themselves, both physically and mentally, and also how to look after their children. And from our preliminary findings, moms have been highly appreciative of how this training is highly developmental.
And does this intervention bring groups of women together? So is that actually also creating a community of like-minded, getting the same education, that then obviously they can have a power behind that? Is that a bit of a thinking that then you're making a big shift, they're not on their own? Because it must be quite isolating if you're not allowed to share those difficulties you're having in that early stages of having a baby.
Yeah, absolutely. So it's a group integrated intervention where in each of the bubble group, if you want to call it like a smaller a subgroup, we have approximately 10 moms who come together for the duration of that 12 sessions of parenting training. But most importantly, the training also help the moms to basically get this parenting skill set that are very developmental and useful for them as moms, and also for their children. It's also help to treat those postnatal depression and anxiety. But most importantly, the intervention kind of help the children of these depressed moms to be able to reach their full potential in life through adequate training that might involve adequate breastfeeding, hygiene, health, mother relationship through attachment, which has always shown to be very useful. So, because this evidence-based, intervention, we assess the moms at baseline, that's prior to the intervention. Then at the end of the intervention, then we then follow up 3 months and also 6 months, just to look at how sustainable this intervention has been on the moms.
And as this thinking, at the very beginning, you were talking about taking learnings. from reverse innovation. Is that where this has come from? Has a lot of this information come or this study come from that?
Yes, absolutely. So again, we are kind of triangulating our evidence, looking at what we found, what is attainable in Nigeria, what is attainable in Kenya, as we've published in our previous studies, and now we're expanding to Jamaica. So all this kind of knowledge have helped us to put this together. So based on our trajectory, we understood that at the minute, it costs the United Kingdom about 8.1 billion every year to finance mental health distress such as depression, anxiety, psychosis, etc. So we understand that the anticipated findings we are going to be getting from our own project, and especially when we successfully completed the pilot and also a a full scale trial, it's going to save the government about 7% equivalent of the of the investment, which might amount to about 21 million savings per annum, and this will be attributed to reduction in disease burden of childhood disorder, reduction in hospital visit with associated to the African and Caribbean communities alone.
And what further do you think needs to be done to change things for the better?
At the minute, to be fair, I feel disappointed that in this year and age, we are the one doing this kind of research that will bring about this tangible and sustainable change. Which means there is a lot more that need to be done in terms of conducting more evidence-based research, that can build resilience in this community, because actually cost the government more money for not doing or investing in mental health among this community. So we also need to think in terms of actionable policy implementation, and that can bring about measurable impact in this community. But most importantly is to then begin to see what we can do within our own reach to bring this change. For example, now my current contribution to the NHS is becoming more practicable and reachable, in the sense that I am also part of the NHS Maternity Service User Equality Steering Group, and of course the lead for the sub group for mental health and well-being. In this steering group, it's a kind of a conglomeration of practitioners from different aspects of developmental and also maternity and care provision among NHS, etc. So we're thinking about how we can actually bring about improvement in the lived experiences and clinical outcomes of women and babies from the BME communities, and especially those that are living in deprived and socioeconomically disadvantaged communities. But most importantly is to also see how we can increase confidence among this community to really access these services that are readily available.
I mean, this episode is going to be released on both Black History Month and coincidentally also on World Mental Health Day. Why do you think it's important to support these awareness days? And do you think there's more steps we can take to improve the visibility of these issues?
Absolutely. So, like I mentioned earlier, our working with the NHS steering group is to see how we can increase confidence in this community. So, I totally believe that there is high level of lack of awareness, and so this kind of more activities that brings about knowledge transfer or knowledge exchange activities, such as this podcast and the conferences that we are organizing. For example, we or this research group has also pioneered an annual conference of also TAG, the International African and Caribbean Mental Health Conference, and this year we are going to be hosting the second annual conference, which is also hashtag IACMHC / -2. This will hold on the 29th of October here at NTU City Campus. So we look forward to as many people who can participate. It also have provisions for both in-person and also virtual participation.
Dung, thank you so much for joining us and sharing all your knowledge, expertise, and telling us all about your research. I know earlier you told me that, this information's out there, but I think for many of us, actually, we're very unaware of it. So it's been incredibly insightful. So thank you again for joining us.
The pleasure is mine.
Thank you all very much for listening. If you want to find out more about Dung's research, please check out the episode description. You've been listening to the Research Reimagined podcast by Nottingham Trent University. For all of the latest news from the research community at NTU, follow us on Twitter at NTU_research or sign up to our research newsletter by visiting ntu.ac.uk/research. Thanks for listening.